Hey guys, Sean Harris here. I'm just going to do a quick conversation, kind of segueing off what we talked about last time. So we talked last time on simple versus complex nerve pain. So what we're going to do today is we're going to talk about the different categorizations of nerve pain. So a question that I get asked all the time, and I hear different things back and forth from PTs, from medical doctors, different things, is cortisone injections. Do they help? When should I get one? How do I know? I had a cousin that said it worked really well for them. What about for me? That kind of thing. So what we need to do, if we're going to talk about whether we get a cortisone injection or whether that might be helpful, is to decide whether this is chemical pain or mechanical pain, okay? And the reason I say that is because I have a saying, we treat chemicals with chemicals. So if you've got a chemical irritation of your nerve or any other tissue really, an injection can help. But if you've got a mechanical problem, and that's holds true even for, let's say, mechanical problems in the knee, right? You might have a torn meniscus or some piece that's kind of hanging around there that's irritating the joint. That injection might help decrease some of the inflammation that's there, but if that mechanical issue is still there and nothing's fixing that, then the injection isn't going to be good enough to just wipe all that pain out, and that's when somebody you might have to get a surgery to clean it up, etc. What is causing the nerve pain? Okay, so how many of us have been stung by a bee, right? Myself. That's a good example of chemical nerve pain, okay, or chemical pain in general. Or if you've gotten a flu shot, that's chemical pain too. Your arm is really sore the next day, you've got to kind of move it around, that gets a little bit better after a couple days and then it goes away, okay? Mechanical is kind of like, have you ever hit the funny bone, right? People talk about hitting your funny bone, that's your ulnar nerve in your elbow. So if you were to take your arm right now and press on there's a little bone right here in your elbow. If you press just underneath that, you're going to hit your ulnar nerve, okay? That pressure there, you'll start feeling some pain. If you hold on long enough, you might feel a little bit of tingling, a little bit of pain shooting down your arm like that. That's because you're mechanically compressing your nerve. Now, when you let go, guess what? The pain goes away as well, right? So there's this what's called an on-off phenomenon with mechanical pain, mechanical nerve pain. Meaning if I were to press on it, there's the pain, or once the mechanical structure is pushing on the nerve, there's the symptoms, and then when it's gone, it's gone. Whereas chemical pain, it tends to kind of linger. Any motion that you move in any direction, if there's chemical inflammation that's sitting on the nerve, all of those motions are going to make it worse. And so what I tell people is that if you're considering getting an injection, if you're considering getting on an anti-inflammatory, all of those things, you want to make sure whether you've got chemical nerve pain or not. Okay. This is overall got to be a conversation that the patient's got to have with the therapist and with their physician, right? So as physical therapists, I'm never going to prescribe anti-inflammatories or an injection. But what I can do is I can make recommendations based off my assessment. And what I always tell the patient is like, look, here's what I think is going on. This is what I think the problem is. I'm not convinced that a cortisone injection is going to help in this case, and here's why. And then I'll talk to the physician, right? So one of the biggest things that we need in our healthcare system is for every person that's involved with someone's healthcare to communicate. And with things as busy as they are, that's the one thing that kind of gets left by the wayside. So that'd be the recommendation that I would also say for new clinicians, or if you're uncomfortable about making a recommendation or saying something that might counteract what maybe someone else has told them. The most important thing is that I have a firm belief that I want to make sure that I give the patient what they need and the patient gets better, and so I put that as my overarching goal. And so I always encourage them, I want you to make your own decision on this one. Here's what I would do, here's my recommendations. Let me know if you have any questions that can help clarify things. And like I said, I have really good relationships with all the physicians that I work with, because the reality is that we're both seeing them, and so the patient needs us to communicate in order for them to get better. So what it comes down to, and we'll talk about this in more detail in other lectures, but nerve pain, we've got two basic categories. We've got tension and irritation, okay? Tension is where the nervous tissue is responding poorly to static stretch. So for example, if you elongate the nervous tissue, that tissue elongation, the nervous tissue itself can't move as well as it needs to, and it causes pain. Honestly, I see this a lot of times in kids that are going through growth spurts. We've kind of figured out, okay, kids are going to grow, their bones are going to grow faster than their muscles, so we know their muscles are always tight. Well, their nervous tissue is tight too, okay? And then they go and they sit in school for 8 hours in a row and then go try to play sports, and they wonder why when they go to bend down and pick up something off the floor, or they're twisting in weird directions, then they get a little bit of like pain up their back or down their legs. That's because the nervous tissue is responding poorly to it being stretched, okay? And so we'll talk about that neural tension a little bit more in another video, but today I wanted to focus on neural irritation, okay? So as we talked about, we've got nerve irritation. It's either mechanical or it's chemical, okay? Mechanical, there's what we call an on-off phenomenon, right? So you press it, or let's say for someone who's got a nerve irritation in their back, they extend backwards or they flex forward. During one of those motions, there's the nerve pain. But then when they get out of that position or they get into a position of comfort, nerve pain goes away. If that's you, the likelihood of a chemical, of an injection helping is a little bit lower because you're not displaying signs of chemical nerve pain. Now, for example, if you're someone who's got nerve pain that just kind of sits there relatively constantly, or it hurts with all motion, whether, let's say, flexion, extension, twisting, if it hurts with all of those motions, any motion, then once you get there, oh yeah, like it hurts the first couple minutes when I lay down in bed, but then after a couple minutes, it kind of slowly eases and it feels better, or it hurts a little bit after I first stand up and start walking, and it slowly gets a little bit better. That could possibly be because you've got a level of inflammation around the nerve, and then once you move a little bit, it feels better. And those are the people that tend to do better with treating with anti-inflammatories, be it oral or injection, okay? So there's a big difference in the way that these two things look, or these three things really, but again, we're talking about these two down here. There's a big difference between the way that those two things look, both in a subjective examination and in an objective examination, okay? Now, before people say, well, wait, hold on, what if you've got both? Of course, you can have both. There's plenty of people that have got foraminal radiculopathy, for example, that feel pain with extension. They go back, it closes the space between their foramen, that irritates the nerve. That's mechanical nerve compression. If that happens too frequently, that's going to cause some inflammation, right? So then we've got both things. And in fact, I would say if you've got a mechanical nerve compression for a certain period of time, the likelihood of you having some chemical irritation to that nerve is very high, okay? But it's not the overarching cause of what's causing the nerve pain. And so then we have to think, okay, if I get this injection, it might feel better for a short period of time, and that's great, and then I need to do something about offloading that mechanical nerve compression while it's feeling better with the chemical or the anti-inflammatory, okay? Whereas if you're somebody that's got just mechanical nerve pain, like literally it only hurts every time I extend backwards, that injection is not going to help you very much, more than likely, okay? And so one, it's a healthcare savings thing, right? If we do a better job of screening who gets these procedures, that saves our healthcare money. But two, it also helps the individual, because I'm not going to waste time and energy on saying, take anti-inflammatories or do this or do that, if they might be better served doing something else that's going to actually get them better, okay? So from a patient perspective, a patient satisfaction perspective, from a healthcare savings perspective, it makes sense to be able to differentiate between mechanical and chemical nerve pain if we're going to adequately treat it. So hopefully that makes sense. Let me know if you guys have any questions and I can help clarify. In another video, we're going to talk a little bit about tension more, because we see that a lot. And as physical therapists, that's something that's honestly really, really easy to treat. And in the later video, we'll talk about how to screen objectively for these things in a lot more detail, because that's really important. In PT school, we hear a lot about neural tension. Neural tension, neural tension, neural tension. It's called neural tension all the time. And a lot of times it's not neural tension. It's one of these two things, and that's going to affect what we do as PTs to go ahead and treat it. So anyways, thanks.